Value-based care might be the most used phrase in healthcare and the least understood. You hear it in the boardrooms, you hear it in policy discussions, and you see it in nearly every healthcare system strategic plan. But if you ask 10 different healthcare leaders to define it, you will often get 10 different answers. And that's a problem. Because value based care is not a slogan, it is not a single program, and it is not simply the opposite of fee for service. It is a fundamental shift in what the healthcare system actually gets rewarded for its efforts. And that distinction matters. Because most explanations describe the mechanics, the contracts, the quality measures, and the shared saving calculations. But they miss the deeper change underneath. And when you miss that, you end up building a value based care strategy on the wrong foundation. Welcome to HealtheNomics podcast. Here we explore the forces shaping healthcare today and tomorrow. I'm Dr. Ayoub Ashraf, a healthcare strategist and a consultant. So, in this episode, I want to do three things. First, define what value based care actually is beyond the textbook version. Second, explain why so many organizations struggle with it. And third, look at what separates the systems that succeed from the ones that stop. So, what is value based care? For most of its history, the healthcare system has been built around volume. The more services delivered, the more revenue generated. That's not a criticism. It is simply how the incentives were designed. And I want to be fair about this because the design was not irrational. When you are paying for a hip replacement or an appendectomy, paying for the service that was rendered is a perfectly sensible way to do that. But it produced a predictable result, a system that rewards activity and not necessarily the outcomes. A system where a hospital can be financially successful even when its patients are not getting healthier. Value based care changes that pattern. It moves the basis of payment away from the individual service and towards the result that service was meant to achieve. And here is where most explanations go wrong. People hear the word value and they assume it means doing less, cutting cost, and reducing care. It does not mean that. Value is not the absence of spending. It is the relationship between the outcomes and the cost of achieving them. That is a very different idea. Because it means the goal is not cheaper system, it is a system that produces better results for what it already spends. Let me give you an example. Think about a patient with diabetes. In a volume based system, much of the revenue around the patient comes from the visits, the tests, and the procedures that happen when things go wrong. The foot ulcer that becomes an admission, the kidney complication that becomes a dialysis referral. In a value based system, the reward comes from keeping that patient stable and preventing the complication that leads to the hospital admission in the first place. Same patient and completely different set of incentives. That is the shift which is made real. You can notice something important in that example. Nobody in the volume based version is doing anything wrong. The care is appropriate, the billing is honest, and every clinician involved is doing their job well. The problem is not the people, and it never was. The problem is what the system pays for. Now, in practice, this shift does not happen all at once. It shows up as a spectrum. At one end of spectrum, you have arrangements where an organization can earn a bonus for hitting quality and cost targets, but loses nothing if it fails. It is upside only incentive. In the middle, you have arrangements where the organization not only shares the saving but also shares the losses. Now there is real money at risk on both sides. At the other end, you have full accountability, where an organization takes on the complete financial risk for the total cost and the quality of care for an entire population. Shared savings, bundled payments, accountable care, and capitation. These are not separate ideas. They are different points on the same line. And that line measures one thing: how much accountability an organization is willing to take for the outcomes rather than for activity. So, when someone says we are doing value based care, the real question is never whether they have a contract. The real question is how far along the spectrum as they actually standing. And in my experience, that single question separates the organizations that are genuinely transforming from the ones that are simply participating. And it is worth asking why the shift is happening now. Because value based care is not a new idea. The concept has been discussed for decades. What changed is the arithmetic. Healthcare costs have grown faster than the economy for most of the last 50 years. Employers feel it in their premiums, governments feel it in their budgets, and patients feel it in their deductibles. At some point, a system that grows faster than the money available to pay for it has to change. Not because someone had a better philosophy, but because the math stopped working. That is the honest origin of value based care. It is not idealism, it is arithmetics. And that matters because it tells you that shift is not a passing initiative that will fade when leadership changes. The pressure creating it is structural, and structural pressures do not go away. So, if it seems that simple on paper, why it is so hard? The answer to this question is not that leaders don't understand the concept. The answer is structural. Because most organizations are not running a value based system alone, they are running two systems at the same time. On one side, the majority of their revenue still comes from fee for service, which is incentivizing volume. On the other, a smaller and growing share comes from the value based contracts, which incentivizes the outcome. And those two models reward opposite behavior. If you want to succeed at value based care while most of your revenue still comes from fee for service, it's a problem. Because every admission you prevent is revenue which you are not collecting anymore. You are, in a very literal sense, being asked to reduce your own income. That is the single most underestimated challenge in this entire transition. And it is not philosophical, it is operational and it is financial. Because you cannot fully optimize for outcomes while most of your revenue still depends upon volume. Then there is a second reason organizations struggle in value based care. Value based care requires capabilities that volume based care never needed. You need data, and not just the billing data, but clinical and population data in close to real time. You need the ability to identify which patients are at risk before they become expensive. You need care management. You need care coordination and follow up that happens outside the hospital walls. And you need physicians who are aligned, not just informed, but actually engaged in changing how they practice. None of that is built overnight. And most of it requires investment upfront before the financial return arrives. That timing gap is brutal because leaders are asked to spend real money building infrastructures today for savings that may not appear for 2 or 3 years. It's a financially pressured environment. That is a difficult case to make. And it is exactly where many value based strategies quietly stall. Not because the idea failed, but because the organization was never structurally prepared to support it. Now we talk about what actually works. So, what separates the organizations that succeed from the ones that stall? In my experience, it comes down to a few things, and none of them are about the contract itself. The first is that successful organizations treat value based care as an operating model and not as a program. This is the most important point in entire conversation. A program sits on the side, it has a small team, a few reports, and limited influence. It reports to someone who reports to someone else. While an operating model changes how the whole organization works, how it staffs, how it measures, and how it makes decisions. Organizations that succeed do not ask, how do we run our value based care contracts? They ask, how do we become an organization that manages the health of the population? That is a completely different level of commitment. And you can usually tell which one you are looking at within about 10 minutes of walking in the door. The second is physician alignment. It is very important because, in the end, almost every meaningful outcome in healthcare is shaped by a clinical decision. If physicians are not engaged through governance, through shared goals, and through incentives that actually make sense to them, the strategy never reaches the patient. It stays in the boardroom. The systems that succeed invest heavily in this area. They bring physicians into the decision phase and not just the rollout phase. And there's a difference between these two things, which is much larger than it sounds. Bringing someone into the rollout is just telling them that what was decided, while bringing them into the decision is letting them shape it. And then the third is leadership patience. This work does not produce results in a single quarter. It requires sustained commitment through a period where the costs are available, they are visible, and the returns are not yet. And the organizations that succeed in this model are those where leadership holds that line instead of retreating the moment the next budget cycle creates pressure. I've spent time on both sides of this, in clinical setting and later in strategy and audit. And what I have seen consistently is that the difference is rarely the model itself. It is the readiness of the organization to actually live inside it. And then there is a fourth thing I would add, which is discussed far less than the three. The organizations that succeed are usually the ones who are honest about which population they are ready to take responsibility for. Because taking on full risk for a complex, high need population before you have built the care management infrastructure to support it is not courage. It is a way to lose money and then conclude that value based care does not work. The successful ones sequence it. They start where their capability matches their accountability, and they expand as the capability grows. That sounds obvious when you say it loud, but it is remarkable how often it is ignored. So let me bring this back to where we started. Value based care is not a contract, it is not a program, and it is not simply a way to spend less. It is a shift in what the system gets reward from the volume of care delivered to the value that care creates. The organizations that understand this concept are building something durable. The ones that treat it as a checkbox are usually the ones that stall. And as financial pressure on the system continues to grow, this distinction will only become more important because the future will not belong to the organizations that will do the most. It will belong to the ones that deliver the most value for what they spend. That is the real meaning of value based care. And that is where most thoughtful leaders are already focusing. This has been HealtheNomics. I am Dr. Ayoub Ashraf. If this was useful, follow the channel and I will see you in the next episode. Thank you.